Hello, good evening. Welcome back to I Care for Your Brain with board certified neuropsychologist Dr. Karen Sullivan. That is me. We are here tonight to talk about a topic that is very important to me as a person and as a professional, and that are my three biggest no's in dementia care. No matter where you live in the world, you are probably going to start to hear something called the National Plan for Managing Dementia and Alzheimer's Disease. This is a federal rollout that's happening because we are going to see a huge bubble in the amount of people living with dementia and other Alzheimer's in the next few years. What we're really looking at by the year 2025, we're probably going to have about 7.2 million Americans, and by 2050, that number is going to double, and we're going to be at about 13.8 to 14 million. So what we really need to do, and thank goodness we're getting more funding for it, is to really look at long-term care services. We need to think about home, community, and residential settings for people living with dementia and their care partners. What we want is evidence-based, person-centered care. So my three no's tonight really focus on this. I started my career in dementia care, and I'm pretty much still in it now. I just see people in a different capacity as a neuropsychologist. So for about 6 or 7 years, I lived and visited with people in their home. I worked in memory care as activity director, and now at this point in my career, I'm probably past the 1,000 mark of diagnosing people with dementia. This is my passion population. Dementia care is some of the hardest yet most meaningful work that we can possibly do. And what is very clear to anyone who's done it or is doing it is how badly we need to advocate for more progressive and more humane care. So these three no's that we're going to talk about tonight are right there, right up front. So the very first one that we all have to really commit to is to not infantilize the person living with dementia. So what does that term infantilize mean? It's basically treating an adult like a baby, right? It's a way of interacting with someone where a person in authority treats someone else, in this case someone with dementia, in a childlike manner. There's a clear hierarchy, treating them like an infant. These interactions in long-term care settings have been proven to make people who struggle with speech respond with agitation, withdrawal, refusal of care. This then gets labeled as a behavior problem, which then has to be treated with a medication to manage. So at the heart of not letting that negative process begin is using a different way of speaking to people who have dementia. The most common way that infantilization happens is through baby talk. Baby talk is a patronizing type of speech in which we get really high in our voice and we start to use little cute words and we start to overly pronunciate and we talk loud and we kind of boss and we are using very childlike vocabulary. It's called this way because this is the way we talk to children or pets even. Despite the fact that these are adults who have spent years and years contributing to society and working. Other common infantilizing behaviors includes overly familiar forms of address like Missy or Buddy or even pet names, or disclosing someone's personal diagnosis status in front of other people as if they weren't present. So, hey, there's that Alzheimer's person, or, there's, somebody who has Parkinson's disease dementia. It's really the first step in objectifying someone. It's really rude and demeaning to speak in front of someone as if they don't understand. You don't really know. All types of dementia are very, very different, and what we really have to keep in mind is that dementia is this incredibly huge umbrella term, and underneath that are all the different diseases that cause the condition of dementia. But we also have plenty of people who are in the mild stage, the moderate stage, or the severe stage, and their level of comprehension is going to differ dramatically across people. So there might not always be a one-to-one connection between what someone's cognition looks and sounds like and what it actually is. With speech, for example, there's a huge difference between expressive issues and receptive issues. So you might not be able to project someone's level of understanding just from their difficulty with word finding. So that's a huge important point, because we don't want to assume that we can just talk about people in front of them as if they're not there. Another way that we commonly do this is inappropriate recreational activities. So this is things like, stickers, childlike games, primary color painted toys. That being said, I'm actually very pro doll therapy in dementia. I'm very pro robo pet therapy. I always prefer to start off with music because it is more adult and mature, and oftentimes music is incredibly powerful in dementia care. But there are some people for whom it is their second nature to take care of something. So whether or not that's a cat, a dog, a baby, whatever it takes, the key is that you want to make sure that the person is going to understand that they're not going to understand that it's pretend, because then it really gets to be a little bit demeaning. And that's a very delicate balance of figuring out who you're going to maybe bring a doll to see if it works. Now, of course, there's usually no harm in just trying once, but what you would never want to do is put someone who realized that it was a doll with the doll, because they could perceive it as you're really treating them like a child. Research has shown that doll therapy and pet therapy can reduce the need for medications, which we love, diminish anxiety, and improve communication. Now, I know some health professionals that work in long-term care, they really think that they're helping by speaking to older adults in a way that's kind of that sing-song baby talk, and they can feel like it's nurturing and supportive. So yes, we do need to slow down and speak louder, because as we get older, we do often have hearing and vision loss, but it's a very, very delicate choice to go disrespectful or respectful. So one of the most important things to keep in mind is when you talk to an older adult with dementia in a certain way, maybe using baby talk, other people around you are kind of getting the rules of engagement for that person. So what I mean is you could really be contributing to a culture of infantilization, not just your interaction with the person, but this person can then get labeled at a level that's lower than their actual ability. So that kind of gets back to my point earlier that we don't want to mistake lack of ability and lack of competence with dementia, because some people with dementia retain competency and some people who don't have competency don't have dementia. So it's not like there's a perfect relationship between those two. You've met one person with dementia, then you've met one person. It's very hard to make generalizations about people with dementia because people come into their dementing illness with their own unique brain, and the process of dementia is going to be very unique for them. So we never want to assume a level of function that is actually less than the person can do. That's something we call de-skilling, which basically means that you're actually lowering their competency, you're increasing their disability by assuming that they're not able to do certain things. So we really want to be operating from a watch and wait perspective when we're meeting new people. A lot of baby talk involves telling people with dementia what to do, and this often doesn't work because so many dementias are focused or have resultant deficits in left hemisphere areas that are dominant for language. So a much more dignified and actually effective way is to mimic, is to demonstrate. So you're going to get much further with someone with dementia by actually showing them so they can copy you than actually trying to use your words. And using your words is going to involve auditory comprehension. It's going to involve short-term memory so they can remember. And oftentimes it actually gets very frustrating for the care partner and the person themselves. Again, you always want to think about what stage of dementia it is. So somebody with mild dementia is going to require a much different tone and word choice than someone with advanced severe dementia. And we just really want to try to find that balance and always lead with being respectful and not patronizing in any way. Sometimes people also feel, especially in care facilities, that maybe they can't speak back to a caregiver who is being condescending because there's this huge power differential. I am the one who needs care and you are the one that gives care. And maybe they just have to go along with it. But they are humans, and it will often come out in other ways that then get labeled as kind of these behavior symptoms. So yes, we want to speak in shorter sentences. We want to speak a little more slow. We want to try to avoid those high-pitched voices. We do want to leave space for other people to be able to respond. We always want to add in Mr. or Mrs., right? We want to avoid things like sweetie, good girl. Any of that stuff is too infantilizing. We also want to make word choices that are the most adult in the moment. So we don't want to call, we could use the word underwear instead of diaper. Instead of saying potty, we could say bathroom, right? We want to make sure, this might be my most important one, is how do we address the actual person? So let's really stop by saying things like the dementia sufferer or the Alzheimer's victim. Those terms have got to go. What we want to talk about is the person living with dementia, right? We want to make sure the person is first and emphasize that they are coping and being flexible with the challenge of dementia. We also are moving towards the term care partner instead of caregiver because we want to emphasize that the person with dementia is contributing to their own care. The next no-no, this is number 2, is to not argue. It will not get you anywhere. Saying no or arguing for the person with dementia is just automatically ineffective and overly stressful. You really want to try to figure out how to use diversion, distraction, white lies, misinformation. All of these things are okay. Saying no is really not going to get you anywhere. They oftentimes can struggle with the ability to reason, to remember what you've said because of some of those short-term memory deficits. And they're neurologically enable sometimes to postpone gratification or explain why it is they think they need to have that thing right now. So what's key is that you are trying to think about the emotions that the person is left with after your interaction. So if you are aggressive and you take something away and you don't replace it, the person may forget the details of your interaction, but they're left feeling agitated, feeling violated. And those feelings, again, then often trickle into not being cooperative and having difficulty on units. So rather than thinking like this is a tantruming child, I am going to think about that I have an intact brain in this moment and I am going to walk away, distract them. I'm going to call their attention somewhere else. If I take something from them, I'm going to have something else to give them immediately. I might even say, hey, I need you over here. That often works really well. The key is not to over-explain. You really want to just kind of do and hopefully the person follows you. Questioning recent memory, saying anything like, I told you that, don't you remember that? All of those things are definitely not good. So if you are in the position of thinking about putting your person with dementia in a care facility, I want you to ask how they handle behavior symptoms. I want you to ask what is their philosophy of care, and most important, what are the actions that they do that brings their values to life, right? It's one thing to say we are person-centered. It's another thing to say, well, how do you show that, right? How do you train your nursing assistants? How is it that you design the activities to show that they are accessible for somebody with dementia? And number 3, and this is probably my most favorite, is to not settle. And there's so many different ways that this is relevant. So don't settle means don't settle across the board. Okay, the first one is don't settle in bringing cognitive concerns to a physician. Okay, research tells us that oftentimes people wait about 2 to 3 years before they bring it up to a physician because they're either overwhelmed, they are afraid they don't want to overreact, they can explain it away through age. So what you're looking for are changes in language, memory, to the point that they impact function. And so finances is very sensitive, remembering to take medicines and driving. So when you start to see an impact there, that's when you really do need to find the words, find the courage to bring it up to a physician. Delayed dementia diagnoses are not good for anyone. They're not good for the person because they lose opportunities for treatment. They also increase care provider burden, because now you're the only one who's kind of holding this information and going behind the person and kind of supporting their function. Once you get to the physician, I also don't want you to settle by accepting anything less than I will get you to a neuropsychologist for an evaluation. On average, it takes 11 long, painful months from the time people complain about memory in a loved one or themselves to getting a diagnosis. That is a year of time. That is incredible. One of the barriers in getting a correct dementia diagnosis, if we look at the scientific literature, is that the provider can have an attitude about dementia that's actually more harmful than it is helpful. And this attitude is that it's just age, right? What are you complaining about? You're 75 years old. This is what happens. If you hear that, you are going to, in your empowered voice, say, dementia is not a normal part of aging, and we need a referral to a neuropsychologist. So if you have a physician that's their attitude, why should we talk about this? It's going to be more stressful. There's nothing we can do. What research shows is the only time that they tend to get involved and act is when there's a major problem. So basically, this is punting the problem back to the family and creating a crisis. A crisis is going to have to happen before a physician is going to get involved. That is not okay. One of the worst things that can happen with physicians with this attitude is that there's research suggesting that a good proportion of people who are actually diagnosed with dementia, so this is over 20% of people, are never told that they have it. They find out by reading their medical records. Now, this is in strong contrast to any other medical condition that you can imagine. Imagine being diagnosed with cancer, and the way you're told about it is through your medical records. I don't think that would be very kindly accepted. But it's also in contrast to what people want. What people want is to have open discussions and full disclosures, okay? If you agree with that, I would love for you to let me know in the comments, because the more people we get talking about this, the more easily we're going to be able to see change. So what people like about their doctors when they go and talk about dementia is open communication, helpful factual information, and empathy, the big word, the one that we all want from brain health providers, okay? So don't settle also applies for, don't just settle for a doctor saying, well, this looks like dementia. Well, we think there's some mild dementia. What you are going to come back and say is, well, we need to know the subtype of dementia, because the subtype is what's going to tell us to do in terms of treatment. Not all memory medications work for all subtypes of dementia. Okay, some work better than others. Some, you got to balance that risk-reward ratio, and you need to know what you're dealing with. So when you go to see a neuropsychologist, that is what we specialize in. So I would love for you to advocate for your person to be able to get that type of referral. If you have Medicare and a secondary insurance in the US, it really shouldn't cost you anything to come see us. Maybe a little copay, but oftentimes zero. So do not settle across the board. The last one is not to settle in terms of care, okay? Taking care of someone with dementia can be a 24-hour job, yet no person is designed to go at that level of intensity for very long, okay? So the other thing is you're gonna not settle for no or poor care. I want you to call your local government agency on aging and ask them what services they have. Sometimes they might not have caregiving services, but maybe they have Meals on Wheels. Maybe they have a home cleaning service. Any help you can get will make the load easier. You also can ask your community for help. Don't settle for people not offering. Sometimes you have to assertively go and tell people that you're struggling. If the person you are caring for has kids and they're not involved, guess what? I want you to call them up and ask for specific help. So you're going to get much further if you say something like, hey, can you come, the second and fourth Sunday of the month and pick up dad and take him out for a few hours, versus I need help. I really would like you kids to do something more. So the more specific you can be, the more likely you are to get a yes. No one person has the capability of taking care of all of the care needs that someone with dementia comes with. And so I really want you to not settle for having to do it all yourself. If you found value in this video, I would love nothing more than commenting, letting me know what you liked about it, letting me know that you appreciate these kind of conversations where we're trying to move the needle ahead on dementia care. Please let me know where in the world that you are listening from. That's always fun. And if you can share it, that's the best. If you're watching us on YouTube, please subscribe to the channel. About once a week, we're trying to get you top of the line, science-based, person-centered brain health information. Thank you guys all so much, and I'll see you again next week. Take care. Bye-bye.